Assalamualaikum and a very good afternoon. I'm Aizuddin Azman, live from Malaysia Productivity Corporation, MPC. Thank you for joining us in 26th series of MPC Productivity Talk for 2022, tuning in every Friday at 3 p.m. Stay tuned.
The global healthcare industry is among the most dynamic and rapidly growing industries in the world. But how can the sector push for more productivity and also accelerate its growth?
The whole aim is to make sure that the healthcare delivered in this country is of the best level, making full use of the resources that we have and the human resource that we have, and making sure of the skills and enhancing these partnerships.
Well, there are a few productivity performance improvements that can be achieved through innovation, adoption of information technology, reducing skill gaps, fostering regional integration, strengthening institutions in the entire productivity ecosystem, and streamline regulations and ensure robust implementation of regulatory reforms.
This is where the Productivity Nexus comes into place to the rescue. It has three main aims. First, assist enterprises to boost productivity. Second, increase innovation. And third but not least, capture growth opportunities.
Meanwhile, the Nexus subsector focuses on residential care facilities such as elder care in residential areas, human healthcare activities such as medical and dental practices, and social work activities.
To enhance further and to promote the expansion of the productivity in the private sector, the government has come up with this productivity, private healthcare productivity nexus, and we plan to look at the ways in which the private sector can collaborate together with the public sector in taking this forward. Can we do things differently? Do we need to change the way we practice and look at private healthcare, the potentials, and to take it forward?
I think it's very important first to collaborate with the public sector. I think one of the key issues that we face right now is one is cost and the second is access to care. In addition, there are various government agencies who have different initiatives. So LPPKN's mammogram screening initiative, we do see patients from there, for MEMA screening as well. Within that, I think the ministry has already tried. For example, they have different schemes for different specialists in the public service now, where they are setting up private wings or they're allowing them to practice 1 day out of 4 days. And this is a way in which they can bridge the gap to keep some of the specialists within the public service, while also allowing them to perhaps see private patients. So I think that area of collaboration in the human capital space is also going to be exciting for the future.
Improvement of productivity requires the commitment from all parties from the private and public sector to explore synergies that can boost productivity performance for the private healthcare industry in the country. I'm Putri reporting for the Private Healthcare Productivity Nexus.
Ladies and gentlemen, digital technologies have the potential to boost productivity growth by spurring innovations, generating efficiencies, and improving service delivery. Generally, digitalization is always associated with smartphones, software, or even the internet. Nevertheless, it is more than that. Data is also an integral part of digital transformations. Our ability to use data to generate, manage, and share valuable information much more effectively and at lower costs will determine the success of digital transformations. Particularly for the healthcare sector, health data harbor superior knowledge. It can help health systems achieve their goals. Data-driven ways of delivering care will provide the right and high-quality health services to the right people at the right time. And this is what Private Healthcare Productivity Nexus, PHPN, established under Malaysia Productivity Blueprint, would like to strive to improve the productivity of the healthcare sector in collaborations with other ministries and agencies. So, the question is, what should we do? How are we going to do it? Find out more with our guest speaker, Mr. Aladin Niazmand, Director of TAHPI, and Moderator, Ms. Nancy Tan, Coordinator of PHPN.
Thank you, Aizuddin, for that introduction. Now we can start on asking questions to Mr. Aladin. Under the 2018 Malaysia Productivity Blueprint, identifying the private healthcare sector as one of the 9 and now 11 subsectors that could potentially contribute to the overall national labor productivity of the country. 70 over government and private organizations zoned in on issues involving workforce and performance, technology and innovation, and regulatory reforms. With your knowledge after working in Malaysia for 14 years, which do you think among these 3 has the biggest number of challenges that must be addressed first and foremost?
It's hard to choose just one of the 3 issues because, in my opinion, all 3 are different aspects of the same issue. That issue is the ecosystem of healthcare. This is a dynamic ecosystem where one thing influences another thing, which in turn influences another thing, and this goes around the circle with the whole thing being dynamic and fluid. So in order to advance productivity in each of these issues, we need to look at the in-between issues and the links. And for that, what we need is a common platform for good information. All the different agencies of governments, private sector, and so on will have their own roles in there, but they all need to have one common platform of information.
I see. Thank you. But can you please describe what kind of framework is required in this context?
I think what's required is a framework of data, correct information on supply, demand, gap, population distribution, population demand for all the healthcare services, and so on. This information needs to be in a unified format, speaking the same language across all the different agencies of government and the private sector. It needs to represent a single source of truth that everybody can use to do their part in the productivity.
With national governments aiming to implement responsive health systems and the other mechanisms and interventions, in what ways will the Health Facility Briefing System, or HFBS, platform and methodology contribute on this part?
Well, HFBS is both a software system, a tool, and a technique. All of it goes together.
Okay.
It starts by simulating the actual society. It starts with population, by age, by gender, by distribution, by number. But then it talks about this predisposition to various diseases, therefore what healthcare services they require. This is all evidence-based, it's based on science, arm's length. Then the solutions will emerge. If this is the predisposition, this is the demand for healthcare, what is the supply of healthcare facilities and workforce out there to respond to it? So everyone, every agency, every sector of the private enterprise can do their part to meet the demand, bridge the gaps, and do their part for productivity.
Okay. But by what metrics can the productivity be visibly measured if the government uses this technology and methodology?
Okay, the usual problem is the time it takes to do almost anything. If we have 1,000 projects across the country trying to improve things, every one of them starts with very little information, sometimes zero information, trying to reinvent all of the data, the analysis of the data, numerous studies duplicate each other, and things take a long time. So one of the metrics is to get to the result of what needs to be done and the solution as to what needs to be done much, much faster. So you just look at the past, how long it took to initiate any of the programs, and then in the future you will see how fast it is how quickly they'll be implemented, how quickly they'll be approved in the first place, and the quality of the outcomes.
Okay. How much impact has this created to the countries using this system?
Well, I've seen them in use for a very long time. Some aspects of it going back 20 years, some more aspects of it which are being offered in Malaysia 12 to 13 years. I've seen situations where private sector was very shy to invest in healthcare facilities, resources, and so on because of lack of information. Private sector is very sensitive to funding. Funding requires evidence on the demand, on the usage of the facilities, and so on. So where do you get this information from? If there is one single source of truth through the HFBS platform shared between the government and the private sector, and it's all in the open, investors, bankers, all types of funders can see the basis for what is required, where are the gaps, and where the country is going, then it's easier for the private sector, for example, to do its part. Any amount of money that the private sector invests in healthcare through different means, innovation, actual workforce, services, and so on, it is money that the government doesn't have to spend or duplicate.
Yeah.
So that is the impact that can be measured easily.
Okay. What are the key steps that the Malaysian government should prepare or do before embarking on this platform to avoid hurdles along the way and to make it succeed?
Well, first thing is to get various parties, the most influential parties, to get on board the idea of a single source of truth. And to simplify the whole thing enormously, source of truth on supply-demand gap and the trajectory of where the country needs to go in terms of solving the problems of the gaps. The various agencies of governments that I've been speaking to, for example, MOH, JKR, MPC is extremely influential in bringing all the parties together, and the private sector, all the operators, all those who provide the workforce, the training programs, all of those things. So if through some agencies such as MPC, for example, all of them can come together and see the benefits of a single unified platform, unified categories, the language that we speak, these things, the numbers that come out, and we all agree to having this common platform, that will have the major influence. And I've seen countries where they started with nothing. 12 years ago, started with nothing. Chaotic systems, bits of information in spreadsheets and paper and books and a few databases here and there. And then after the implementation of the system, in a very short time, they all get used to going to the one place to get the information. And if somebody else checks on that, goes to the same place for the information, and therefore decisions are made quickly. Results are seen very rapidly. And we've got from a situation of extreme gaps in healthcare to almost oversupply. So we've seen it happen very rapidly.
Okay. Well, there are cases of effective and well-functioning mechanisms for receiving fully and utilizing the system. Government on all levels is often hampered by resources and other constraints. Do countries using HFBS, architecture or service planning or insurance or combination of any, require different approaches to overcome these respective constraints?
Well, of course, every country is different and the circumstances are different. But I've seen in numerous countries the common elements as well. The same patterns seem to repeat and they converge. And the solutions are very similar as well. For a start, productivity effectively means doing more with less. More outcome with fewer people. More outcome with fewer skills. In fact, as I said, doing more with less. So at the start, there'll be some problems. People are used to legacy systems, whatever they've had before and so on. But very soon, as they see elements of the single unified platform come through, they'll be very happy to map all that data, all the things that they had before that they're used to the new system and start using the new system. It's like there was a day, I remember the days that we didn't even have spreadsheets. Okay, paper,
Yes.
pen, calculator, right? And when spreadsheets came, did we complain? No, we didn't.
No.
We used a new tool and we did what we did before. In the same way, when the new tools come in, people very quickly get used to them and don't want to look back. So that pattern I've seen many times, and I expect it to happen here as well.
Okay, thank you. But what are the key components of the system, and is it possible to implement some of them and not the others? Would that work? Would it be possible for them to be in stages?
It's certainly possible to do them in stages. In fact, there is a staging program for them, but it's highly recommended that even though there are stages, approve the stages ahead of time so that forward preparation can be done for the next stage and the next stage and the next stage, rather than say just do this part and then stop and wait for another approval and then move on. That would not be a good idea.
All right.
For example, the sequence of stages would be supply capture, to capture all the information on what is out there now, services, facilities, workforce, by location, by number, by categories. Okay. Then after that comes population-based demand, and then after that comes gap analysis and so on, all within a platform. So you could say, let's do the supply part first, and then do the demand part, and then do the gap analysis. But if you leave too much distance between them, then in one stage you can't look forward and do some forward work for the next one, preparation for the next one.
Exactly.
So,
yes.
okay, they go back to back, but all of them should be approved at the start.
Yes, okay. Our last question, last but not the least, do you anticipate that there might be implications for health researchers as well as the national and provincial policymakers seeking to enhance health system? Or do they have to sacrifice some of the work done in the past or being done now?
Well, absolutely, they don't have to sacrifice anything.
That's
because
good.
Information is always welcome, and you never squander good information. If information is correct, it is part of that hidden single source of truth. You can't destroy truth. So if something is correct, and let's say one agency of government has correct information on the current supply, maybe it's a classification and registration of the workforce, accreditation of doctors and nurses. Okay, let's say that is good information. It will not be squandered. It will be mapped to the new system. And once a better tool is available using the same information, then the old tool goes away, but the information survives.
All right, yes.
Now, once you have this common platform, then the workforce is related to the facilities. Facilities are related to demand, supply, and gap. Then researchers will do the continuation of the research in the new platform rather than the old platform, where there was friction all the time, bits of information everywhere. It's a difference between going to an ancient library, pulling a book from here and there and there, or today you go to and do a Google search, right? So you get instant results out of the combination of all of the data sources.
Thank you very much, Mr. Aladin, for the wonderful answers that you have given to us. I now hand over it to Aizuddin.
Did you know that the moment a hospital is built higher than 48 meters, it is considered a high-rise hospital? And unlike the hospitals that were built during our forefathers' time, a high-rise hospital needs to follow certain requirements that it is safe for all: the patients, the staff, and the visitors. That's when the HDMP, or Hospital Disaster Management Plan, comes in. Now, how does one submit a HDMP? Take Company X, for example, which plans to build a high-rise hospital. There are 8 processes of setting up a private hospital. These 8 processes include submission and approval from local authorities and CCAPs, site monitoring and interim inspections, issuance of CCC, and finally submitting a license to operate. However, to make sure that the plan for the high-rise hospital is routed properly, the most vital step is the submission of the approval for pre-establishment application to Private Medical Practice Control Section, CCAP's Ministry of Health Malaysia. Without this step, Company X's dream to execute a soaring high-rise hospital might not come to reality. This step requires the team, Company X, to submit a Hospital Disaster Management Plan, HDMP, together with the pre-establishment application. What exactly do we mean by Hospital Disaster Management Plan? A Hospital Disaster Management Plan is a set of documents that covers the minimum 4 criteria to ensure that a high-rise hospital plan adheres to the best safety measures there is. The first criteria for an applicant to look into is the high-rise hospital design principles. Company X must justify the proposed location and state the design brief and intention in achieving a safe hospital. This includes an explanation write-up that takes into consideration how the World Health Organization describes a safe hospital, while complying with Uniform Building Bylaws, Private Healthcare Facilities and Services Act 1988, Act 586, and other relevant local building codes. The second criteria is risk assessment. This is to ensure that the building plan has identified potential hazards and risk factors. This includes external hazards such as geographical conditions, as well as internal hazards such as biological hazards, fire hazards, and more. Once the hazard risk has been identified, it has been analyzed, evaluated, and Company X must also propose guidelines to control these risks. This brings us to the next criteria: prevention and evacuation strategy. Must come hand in hand with the risk assessment. Company X must also provide the strategies along with both written and pictorial diagrams to illustrate how the risks can be prevented and the evacuation strategy if something unwanted happened. This prevention plan must consider all factors such as design and planning, compartmentation and refuge strategy, fire protection installation and operational, and awareness on fire safety and more. The last component of the Hospital Disaster Management Plan is the operational planning. It is a framework that outlines the standard operating procedure and scope of personnel who are involved during an event of disasters. This operational planning must include an emergency response plan, execution strategy, proper maintenance, and housekeeping. This is important to provide a safe environment to the high-rise hospital. As vertical healthcare design is becoming more and more popular, the Private Medical Practice Control Section, CCAPS, has worked together with Private Healthcare Productivity Nexus, PHPN, under the Malaysia Productivity Corporation to come up with the Handbook on Technical Design Reference for Disaster Preparedness in Setting Up New High-Rise Private Hospitals. This handbook is especially curated to facilitate organizations to build a safe hospital for a better Malaysia, which ultimately increases the quality of the country's healthcare system. Please get a copy of the guidebook from the www.medicalprac.moh.gov.my or www.wayup.my.
Thank you to our speaker, Mr. Aladin Niazmand, and moderator, Ms. Nancy Tan, for a very fascinating and insightful discussions. Ladies and gentlemen, one thing that we should learn is that digital transformations is a complex, system-wide change that requires leaderships and sustained investment. The investment may not need to be in hardware or infrastructure. In fact, the critical areas may involve building human capital and expertise, adapting processes and workflows alongside modernizing policy and governance frameworks. It also means reshaping fundamental policy settings such as payment models, which influence incentives and behavior across the health system. With that, we have come to the end of the sessions. Thank you for your kind support, and we look forward to meeting you in the next series of MPC Productivity Talk. Hope to see you again next Friday at 3 p.m. Stay safe, stay positive, stay productive. Thank you.